Hello, my name is Niall McKay and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease. Welcome, Gideon Hirschfield. It's great to talk to you again, and I believe you've had a move since we talked last.
Yeah, it is good to talk to you, Niall, today. So yes, I'm now based at the Toronto Centre for Liver Disease, where I manage autoimmune liver disease patients, including a very large cohort of patients with primary sclerosing cholangitis, myself and with my colleague, Dr. Leah Gulhem-Hussain.
Today, we'd like to talk about the clinical treatment of PSC, particularly with the infection or cholangitis. So I guess we could start. Could you give us a brief explanation of what cholangitis is and what it does?
Yeah, and I think that's a really good question. I mean, cholangitis really just talks about inflammation of the bile ducts. And in the case of PSC, that's the medium to large bile ducts. And that inflammation can be from the immune system, and it can also be inflammation from infection. And that infection can be bacterial or fungal infection. So in primary sclerosing cholangitis, it's actually slightly complicated because the disease is a cholangitic disease, and that is what's happening. But at the same time, and we don't really know the sequence, it's like a circle. At the same time, patients with PSC will frequently have infective cholangitis on top of their disease, which is usually bacterial in nature. And I think they probably have this a lot more than they even know about. But when it gets particularly noticeable and the body can't control it, either because the infection burden rises, or probably because of a combination of the strictures that you get from the inflammation, plus the bile then doesn't flow properly and is sort of more granular and more stony, then I think it comes to fruition for patients.
And what it kind of does, if you like, and this is not a clinical description by any means, but maybe you can lead me through it. But what it does, in a way, is the infection kind of hides behind the strictures that are there, or kind of gets into the strictures in some way, does it?
I think so. I mean, I think really what you have is a physical process that goes on in patients with PSC. You've got multifocal stricture. That means the strictures are in more than one place. The bile doesn't drain properly, and then sometimes drainage gets better, then drainage gets worse again, then gets better, plus or minus you may have a stent. And so, yes, that bile then can get infected, and the lining of the bile ducts can get more inflamed and infected. And exactly as you said, it's sort of hiding there, and then it sort of appears, and then your body tries to get rid of it, or sometimes you need help from antibiotics to really push away the bugs that are living in the bile, so that you go back to where you started from.
And how dangerous is, well, first of all, actually, is it a case that there is some infection possibly all of the time, or and it becomes worse over a period, or is it that the infections are cleared by the antibiotics and then come back again?
Well, that's a really good question. I suspect at a low level, there is infection all the time. And I saw a poster, I think, just flew past me when I was looking at the recent International Liver Congress, talking about infections in the bile, whether they're bacterial or fungal, as being prognostic, delineating patients who are going to run into problems. So I think that if you use the best techniques, the bile is never sterile after a certain point in PSC. But it's only clinically relevant when the burden of infection reaches a certain threshold. And that threshold differs between patients because the burden of strictures differs between patients. Some patients have a very single stricture, which is very, very narrow in the largest bile duct, the common bile duct. Other patients have got much more diffuse stricturing throughout the bile ducts. And so you've got this sort of composite of different things going on, which is why it can be so different for patients. Some patients, are admitted to hospital with fever and pain and bugs in their blood, but that's actually quite uncommon. Other patients are managing it more on home antibiotics. Other patients have years and years of no problems and then run into a problem with one single stricture with an infection that is then fixed by or temporized by ERCP, by endoscopy dilating that stricture.
And of course, if you have them in the small bile ducts, then trying to do ERCP doesn't work. It's only in the large bile ducts.
Well, that's the point, isn't it? ERCP has a role in PSC because the disease is physical, but there's a limit to what ERCP can achieve precisely because this is multifocal stricturing. This is in many different places. And the ERCP doctor cannot reach every stricture, cannot fix every stricture. And they don't always know which stricture is what might be used the term dominant, is the one that's causing most of the problems. So they will often agonize about doing the ERCP because the last thing they want to do is introduce infection to the bile ducts. And then when they do the ERCP, it may be unclear until you've tried whether or not it helps the infection and or the jaundice. And it can be very difficult because quite often, in fact, it's the antibiotics that solves the problem, and the ERCP is more like a knee-jerk response that people want to try and unblock the system. And it's very unclear whether which one is helping.
And is there, do many PSC patients, is it critical? Do many patients die of infection?
Good question. Fortunately not. I mean, fortunately, we were quite good, and we have transplantation, which is an excellent option for our patients. And I'd say that dying of true infection from cholangitis in PSC is unusual. Remember, and that is precisely because the PSC patient gets used to having infection, and in fact, their body is trying to deal with it all the time. And so, they're working on treating infection. So it's unusual to get overwhelming sepsis. Certainly, we ask our patients to take it seriously. And of course, it's a very difficult disease. Don't get me wrong. PSC, living with PSC, looking after patients with PSC, it's very difficult. And there are a small number of patients who run into real problems with very bad stricturing disease where we really struggle to clear the infection and clear the jaundice. And those are the patients, of course, who we work very hard on beyond other patients to get them a new liver, which is a very, very good solution to a very complex problem.
But you can have, unlike, say, other types of liver disease, there's often, with the PSC patient, there's often not the slow, steady decline that you get with cirrhosis. I mean, cirrhosis does occur, but sometimes you can live quite well on a small part of your liver.
Absolutely. And that's in fact is one of the challenges and one of the successes at the same time. The liver is phenomenally forgiving. And our patients with PSC live with PSC for decades and decades, which is great. Okay. And they can have decades with no activity, or they can have intermittent trouble and then have another 5 or 10 years where nothing happens. They have a real run of bad luck with infection. They need lots of antibiotics. They need ERCP. But you get them through it, and then they go back to having a quiet time. And that's because PSC is a very unusual liver disease whereby, although it's immune-driven, it is attacking tubes. And it attacks tubes in different places. So it is complicated. And some people's tubes drain better than others. Some people only attacks one bit of the tube. Other people, they get very rapid tubular inflammation and scarring. And then on top of that, as you have impaired bile flow, then you will develop cirrhosis. You will develop scarring because the bile cannot flow out of the liver correctly. And so you get the secondary biliary cirrhosis, which is a feature of PSC. And that is also contributed to by inflammation from the immune system, which spreads and which is not only attacking the bile ducts, but we can also see in the sort of the liver cells actually, throughout the liver. So this is why, studying and developing new treatments for PSC and giving, black and white answers for PSC is so hard, because there's a community of patients with a single disease. In fact, there's a huge variation in how the disease pans out in any individual and over time. And I always tell my patients, some of them say to me, "Oh, do I really have to come back for follow-up? I feel well." And you say, "Well, yes, I like you to come at least once a year, just in case." Because it can change. It can change rapidly. It doesn't change rapidly often, but if a tube blocks, and then the patient goes from normal liver tests to being jaundiced. And that's one of the challenges and one of the advantages, I would say, for trying to get your care in a centre which has got a few patients with PSC. The more patients they look after, the better that clinician and the team has of the spectrum of how PSC behaves.
And with that, how, and we're not talking about vancomycin, but how does the long-term treatment of antibiotics work out with these patients?
Well, there's no evidence at present that antibiotics change the frequency, to change what will ultimately happen to patients. So we use antibiotics predominantly in our practice for patients with intermittent symptomatic cholangitis. And our approach is to start off with having some ciprofloxacin at home, and the patient uses it if they get symptoms which fit with cholangitis, a fever, increasing itch, they notice their urine goes dark, they have an increase in pain, they have a feeling, a wave of feeling ill which comes over them, sort of they feel achy, okay? And they use the ciprofloxacin for 10 days or 2 weeks. Then they progress to maybe taking the antibiotics continuously because we get breakthrough infections. And when we give continuous antibiotics, we might give ciprofloxacin alone, or we might rotate. We might give 2 weeks of ciprofloxacin, 2 weeks of amoxicillin clavulanic acid, 2 weeks of cotrimoxazole, and we'll rotate them. We may even talk to our infectious disease doctors because the antibiotic choices for cholangitis, which are given by mouth, are not great. And then if people get sicker and need hospital admissions, then obviously we move on to intravenous antibiotics. So we have the spectrum. And certainly when we do that, we do temporize, we do ameliorate, and we do prolong the life of that liver. Although we don't believe that those antibiotics per se are slowing the progression of the underlying disease.
I see. And is there a point at which, say, a patient might become resistant even to rotating antibiotics?
Yeah, that is true, and that can happen, although I'm never sure whether it's true bacterial resistance or whether it's really that the strictures have got worse. It doesn't matter how much antibiotics you give, the bile doesn't drain adequately, and that's why they progress to need a liver transplant. And we will transplant patients with recurrent cholangitis who don't have cirrhosis or liver failure. They will get access to transplantation, although they'll need MELD exception points because their MELD score is often low. Their jaundice is often low in between infections. So true infection, true multi-drug resistance is fortunately less common. It can become an issue, when someone is very, very sick and waiting for a liver transplant and has been in hospital a lot. Then we do call upon the help of our infectious disease colleagues to try and make sure we've really thought through which antibiotics someone needs. So, what you're alluding to is we are careful about the use of antibiotics because we don't want to precipitate antibiotic resistance or antifungal resistance. But it can be a clinical problem, but it's not a frequent clinical problem.
But do you run the risk of, say, somebody getting an infection that you can't clear?
Look, PSC is a difficult disease, and so that can happen. But that would be an indication for liver transplant. That would be an indication to try and drain the bile ducts, either by ERCP or by a radiologist sticking a tube into the liver. Now, the problem with those approaches is they each carry risks as you step up, and then you may be stuck while you're trying to get someone a new liver. And as you know, getting a new liver is very different depending on where you live, organ availability, organ allocation rules, whether you have access to live donor transplant. And so all of those things factor into our treatment. So we do have some patients who end up with external drains for their PSC, although I must say we would prefer that decision was made in conjunction with the transplant center, because usually once you're at that point, what you need is a new liver, and that should be the focus. And it can be quite miserable for patients living with external biliary drains, with the sort of managing those drains. So we do our best to make those decisions as a team at the right time.
So, but in general, it sounds like the best possible thing you can do for a patient is to keep them on their own liver, even if you have to treat them with antibiotics continuously.
Yeah, absolutely. We're not going to start the journey of transplantation until someone really needs it, which is why we go through that process of home antibiotics, rotating antibiotics, intravenous antibiotics. Is there a stricture that can be improved by ERCP? Because although liver transplantation is a very good operation and it's a very significant success story for patients living with PSC, at the same time, you don't want to start that journey until you need it, because you can't stop. Once you started, you've got someone else's liver, and that brings a whole set of other potential obstacles that you have to sort of consider. So definitely, we're working around optimizing medical management, optimizing all the things we can, and I always say to my patients, making sure that you're not too early or too late for a liver transplant. And the timing of transplantation in PSC is an art as well as a science, and it takes a lot of experience to navigate that. And patients also don't want to be heading to transplant till they need it.
Yeah, of course. Are there other therapies emerging down the road? Like I've come across phage technology, is it?
No, I think there may be other technologies. I mean, I think I'll say that endoscopy's got better. So we're always asking our endoscopy doctors who do ERCP whether their technology is better. There are new antibiotics, and there are new ways of treating infection in the bile duct. So phage technology is fascinating because bacteriophages have been used to treat bacterial infections for a long time, actually. And these are sort of, what you're doing is using a sort of curious sort of virus-like particle that basically bumps off and kills very specific bacteria. And in theory, you could make that a bacteriophage cocktail specific to a patient if you could culture all the antibiotics. So there are a number of companies out there trying to think about how that would work. And there's definitely some logic. There's definitely evidence, as I alluded to, that once you've got infection, that drives PSC progression. And that makes sense. Once the biliary tree is inflamed, it's never the same. And so it's got the inflammation from the immune system, and then it's got secondary effects of bacterial or fungal infection. And they are driving the disease forward together. So it's certainly the case that there is the hypothesis that some improvement in outcome is possible when if you can treat the infection better. And we do hope that there'll be more opportunities to treat infection in PSC. Our challenge is often we don't usually grow a bug because we tend to only culture the blood. Trying to culture bile is okay, but you can't actually get sterile bile, if that makes sense. When you try and sample bile during an ERCP, that's a good start, but it can get contaminants just from the small bowel of the patient. So you've got these sort of real world checks about how do you work out what bugs are in someone's bile.
And what about because I feel like we're sort of maybe in space sense at the point in which we sent a dog into space, but we haven't quite landed on the moon. But in terms of the microbiome and the conversation that seems to be going on between the stomach lining and the liver, if you like.
Yeah. Oh, I think we're at a point where we can understand it more, but I fear. I would love there to be a eureka moment where we say it's a bug X or a bug Y. I suspect it won't be that simple. It doesn't make sense to me. We live with millions of bugs, bacteria, viruses, and fungi in our bowel. And the bugs and bacteria, viruses, fungi in our bowel is affected by our liver health. And so there's a continual cycle that, so what comes first and then what changes it? If you're yellow, then your bugs in your bowel are different because less bile is going into the bowel. And so, I think what we'll discover is that it's a pattern of changes that we need to attack, and that we may definitely be able to modulate what goes on in the liver by modulating what goes on in the bowel. And it may also be the case that we can modulate what's going on in the bile in terms of infections, and that could contribute to treating of PSC.
I see. I understand. And are there other, like I know that you're running a very busy clinic there in Toronto. How has that been going? Have you been able to make scientific progress there as well?
Yeah, we are. I mean, our challenge at present is we've been building up the program even more. I think our program is thriving. We are and happy to see as many patients with PSC as possible, and we've got a portfolio of clinical trials and other studies. We've obviously taken a hit, that should I say, with the pandemic, and we're resetting how we're going to do research in the future, because the pandemic came with challenges, and we didn't stop seeing patients. We moved to a completely virtual program, and no one was missed. But what that has meant is that now we need to work out ways to do clinical work and research where patients may not come to the center as much as they used to. So we're figuring out, as the world reopens, we hope come the fall, how that will look. Because actually virtual medicine is very appealing to patients with PSC. Most of my patients, all of my patients with PSC are articulate, technology savvy, and doing clinic by webcam rather than doing a 4-hour round trip to clinic has been a major step forward in the quality of life for patients with PSC. And now I just need to align that to making sure I can still do research as well to try and help them get the treatments that they want.
Because the main problem really is I mean, not the main problem, but your major tool is doing blood work as well, isn't it?
Well, that's the point, isn't it? We need samples. We need liver biopsies. We need maybe in the future samples from people's bile. We need their urine. We need their blood. And so, that's where you're getting the value for clinical research, because you can only experiment so much on mice. They're not humans. They don't get PSC. They get inflammation in their bile ducts. So we need to measure things before and after interventions in real people. We need to recognize it's quite slow to learn about new drugs and to make the solutions and progress that we want. But ultimately, yes, we do need those samples. And so it's a fine balance, isn't it, where we are desperate that our patients with PSC get on with life, are not inconvenienced by their healthcare, get the best tests, the best MRI scans, regular fiber scans, regular ultrasounds, blood work. And we balance convenience with also the fact that unless we encourage opportunistic and essentially philanthropic research by patients, we won't actually solve the problems. We'll describe them, and we can describe them better and better, but that won't give patients new drugs. And it's new drugs that they want so that they don't need new livers.
Any particular progress in recent, in the last, couple of years or last 3 years or whatever that you feel excited about?
Well, I mean, I think we're excited that there's 2 phase 3 clinical trials. Time will tell whether they have the solution, and there's a number of phase 2 clinical trials. And I think we're excited that there's a real effort to have more international cohorts and databases and collaboration. And there's an effort to think beyond the classical approaches to treating PSC into approaches either immune regulatory science or microbiome science. So, and we may be the beneficiary of all of these new technologies that have been pushed forward by COVID. So if you can make an mRNA vaccine against COVID, you can do lots of things with mRNA technologies, which can target upregulated or downregulated genes. If you can turn off a single gene using technology that targets the liver, where you can literally turn off one gene's production to treat a disease, a single gene disorder. So in the future, if we understand which genes are bad for patients with PSC, we could work on that. And then, of course, we're excited with the idea of organoids and, reconstructing the bile ducts. for down the line when we're going to be really revolutionary in our treatments for patients with all diseases.
Where you could simply replace a bile duct as opposed to a whole liver.
Well, I wouldn't like to use the word simple, but certainly that is the goal, isn't it, of people who are working on artificial organs and organoids, recreating bile ducts in the test tube so that could then become bile duct that goes into someone's liver. I have to say, it's definitely doable. There are some challenges in that the bile ducts are buried within the liver. It's not like you can take out the bile ducts and just replace them. But, the idea is definitely there and makes sense. And it may be that you can infuse new cells and then they'll sort of grow and they'll know what to do. Some will turn into liver cells, some will turn into bile ducts. This is all definitely science at the moment, and we are many years away from realizing it, but it's definitely exciting.
Wonderful. Is there anything you would like to add? I think we covered most of the infection stuff. Is there any questions I didn't ask that I should have asked?
No, I think you covered everything that I think is important. I think the message always remains this is a difficult disease. It's difficult for patients. It's difficult for clinicians. We don't always know what's perfect. We do know that patients with PSC need new therapies, and they definitely deserve all the attention that we're giving to try to, as a group, and it's not going to be one person, it's going to be thousands of doctors around the world and tens of thousands of patients to make a difference in the future for their disease course.
Wonderful. Thank you very much, Dr. Gideon Hirschfield. It's been great talking to you.
Brilliant. Well, have a good day, and I hope this was helpful.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.